stomachs nice and full for the winter ahead of us. These very difficult, harsh winters that we have here in South Carolina. Thanks for everybody for joining us. Dr. Wunderlich is here to talk with us a little bit today about our pediatric spinal cord injuries and some things related to that to kick off our week of special populations. And so we will turn it over to her to go ahead and get started.
Okay, thank you. Can everyone hear me all right?
Yeah, we can.
Okay, wonderful. Okay. All right. So pediatric spinal cord injury is something that you will likely or possibly see on the acute wards. And wanted to show you, this is what we will discuss today. And I wanted to let you know that this talk is actually an abbreviated version of 5 different talks because spinal cord injury is quite complex. And these are the things that we're going to focus on today. So how often does spinal cord injury occur here in South Carolina, and is it really important? Well, we know that nationwide, spinal cord injury happens in about 5% of kids less than 15 and overwhelmingly male. We also know that motor vehicle crashes are the #1 cause of spinal cord injury across the age spectrum, followed by falls in the under 2 or sports in the 10 and 16s and above. In South Carolina, we have this study from Saunders, which was an actual surveillance registry. It was done down in MUSC for a 15-year period, and it stratified kids 0 to 15 and 16 to 21 years. And they found that there was about 500 cases of peds spinal cord injury in that 15-year period, and almost 3/4 male. They also found that motor vehicle accident is #1 cause of spinal cord injury in South Carolina, just like nationwide, but that violence is #2 in our state. And then sports, which is different from the nationwide motor vehicle falls then violence incidences. And unfortunately, violence occurs more in our non-white population than our white population. And just to kind of bring home the point about how much spinal cord injury we have in our state, you can see that it's less than 5 per 1 million internationally, about 20 to 1 nationwide, and in South Carolina, almost 27 to 1 million in South Carolina. So you can see that we definitely have a higher incidence of pediatric spinal cord injury in South Carolina. So the ways that our children are likely to be injured, #1 is motor vehicle accidents. And please remember, do not let your nephews and nieces or any young children ride in the front seat. The airbags are like little decapitating devices. Early on in my fellowship, I can remember that there was this lovely grandmother who was about 4 blocks from home, and her 4-year-old grandson said, "Oh, please, Grandma, just let me ride in the front seat for the last few blocks home." And so she let him, and unfortunately there was an accident and the airbag deployed, and he had a high C1, C2 injury and will be forever vent dependent and not be able to move his arms or legs. Please keep young kids out of the front seat because of airbags. In teens, violence again is higher in South Carolina, and where I trained, unfortunately, there was a lot of gang violence, and there they used to shoot kids in the back of the neck because they knew that they would live and be a symbol to other gangs of their power. So thank goodness that's not a trend here, but gunshot wounds are a high cause of spinal cord injury, especially in our teen populations. And our kids are not necessarily in gangs that get spinal cord injury from gunshot wounds. They could just be innocent bystanders, and that seems to be the majority of the kids we see here. Other things that can act like spinal cord injury and thus are treated similarly are things like transverse myelitis, spina bifida, and spinal cord tumors. And kids with child abuse can have a spinal cord injury, as can kids with Downs and juvenile idiopathic arthritis secondary to C1, C2 subluxation. Okay, this is where I hope someone will unmute themselves and let me know how many cervical vertebrae are there compared to how many cervical spinal nerves. Any takers? Hello?
Is it one more nerve?
I can almost hear you.
So 7 vertebrae and then 8 spinal cord nerves.
Ding, ding, ding. Yes, very good. The first one goes above C1 and all the other spinal nerves go below the vertebrae. That is right. So she said, see, there's 7 cervical vertebrae and 8 cervical spinal nerves. Thank you. When we think about spinal stability and whether or not neurosurgery or orthopedics will have to do surgery to stabilize the spinal cord, we think about the 3-column theory. And you can see here, this is the middle column, the posterior column. Remember, the spinal cord's going here, and various ligaments make up these columns. And really, the important thing is if the middle column is affected or any 2 columns are affected, that is an unstable spine and will need surgical management. Remember that the spinal cord is also a relay station with lots of signals from the brain for movement and lots of signals going up from the body sensory-wise to the brain. And it's important to remember our long tracks. And for those of you that have done clinic with me, you will know the cortical spinal tract, important for spasticity over here, as well as movement and tone, are 2 of the ventral and lateral are important for motor movement, but also here, remember our dorsal columns, and they're important for fine touch, proprioception, and vibration, as well as our lateral and ventral spinal thalamic tract. Remember those important for crude touch as well as pain and temperature. Okay, so these long tracks also have implication in spinal cord injury. Remember also our cortical spinal tract decussates, crosses over in the pyramids. And also there is a homunculus in the spinal cord itself as well. You can see here in the dorsal column, cervical, thoracic, lumbar, sacral, same in the cortical spinal tract, cervical, thoracic, lumbar, and the spinal thalamic tract. Okay, so this also has implications for injuries. And lastly, the blood supply is important in spinal cord injury, more in adults than kids. And in fact, these syndromes are very rare in children. The most common of these incomplete syndromes is a central cord, and that's the one you may see in a rare adolescent. And that is when arms and hands are more affected than the legs, okay? Arms and hands more affected than the legs, and there can be issues with fine motor, etc. But again, these incomplete spinal cord lesions more common in adults. And differences between adults and children are important in that, remember, children have very cartilaginous vertebrae. Their vertebrae are more horizontal compared to the more vertical in adults. The spine in children is more stretchy. You have more stretching than actual bony breaks, and you have big heads. I always think of children as bobbleheads, as they have a large occiput, and then that makes that fulcrum of the most injury at the C2, C3 level, as opposed to adults at the C5, C6 level. So that big head, bobblehead, and that fulcrum at C2, C3 level causes a cervical spine predilection in children. In other words, kids have more cervical spine injuries than adults. And it's important to note that kids act more like adults at 8 years because that's when your bony skeleton is mostly developed. Skywara, spinal cord injury without obvious radiological abnormalities, is a term that you may hear. It's less common now because we have better CT scanners and you can see these injuries on MRI. In the older days, this was referred to as a delayed onset of paralysis when you couldn't see it on the older CTs. And this is because of that elasticity of the fibrocartilaginous spine and all the other differences that we discussed on the other slide. Skywara, if there's only mild neural injuries, they recover well, but if it's complete, they don't have great recovery. So how do we determine what level of injury? And that's by our ASIA exam, the American Spinal Cord Injury Association exam. And this is an overall picture of it. And then you can see it's broken down. This is broken down into key muscles and sensory points. We've got great key muscles between C5 and T1, and then L2 to S1. But in between T2 and L1, we kind of have to refer on the sensory levels. And what we do is we find the most fully innervated level. For example, if it's going to be a key muscle, we find, where is it, 5 out of 5 strength on both sides, and that would be the level, or at least anti-gravity with 5 out of 5 above it. And then the other one, sensory, you have 0, absent, 1, incomplete, and 2 normal. So if you have a 0 or 1, your sensory level is not normal. So you need to have a 2 out of 2 sensory level. So whatever the most caudal level of full innervation, motorically or sensory, that's how we determine the level of injury. Key in this is sacral sparing. And sacral sparing is being able to have any sensation in the sacral area or volitional anal muscle contraction. It's not the anal wink, which is a reflex, but it's actual squeeze my finger on command kind of volitional muscle contraction. Usually we're able to tell whether or not there is sacral sparing by talking to the nurses and seeing, does the child feel when they're having bowel cares, when they're being cleaned up in that area? Can they actually tell when they're being touched? And then in older kids, we might actually check for voluntary muscle contraction. But sacral sparing is key, because if you have some sacral sparing, then we know that you have an incomplete spinal cord injury. Some signals are coming through, and that has major implications for prognosis. If you are complete, you have no sacral sensation and you have no motor movement in the sacral area, then you have a complete injury, okay? And that means Asia A. Okay, so moving on to the management. The young children have different management than the older children, and that's because they have those big heads and they need special backboards. Also, if they're crying, check end-tidal CO2 because it might mask respiratory failure. Most people will use steroids if it's early out and they're not sure whether or not it will make a difference, but it's unproven in pediatric spinal cord injury. Kids that bite themselves or have other irritability, that might disguise autonomic dysreflexia, and we're going to talk about that later. Kids, especially our kids with spina bifida with good hand function, at age 5 and 6 can learn to self-intermittent calf. Having a DVT is pretty rare in young kids, but when kids start looking like adults, then it's more likely. In adults with spinal cord injury, we just focus on relearning tasks, but in kids, we need to also relearn tasks and achieve developmental milestones. And we all deal with children and we are very familiar with developmental stages, but in spinal cord injury, you also have to think about development. For example, in our preschoolers, magical thinking. They might think that they're going to magically heal and be able to walk, just like in the cartoons. Or they might think that they did something wrong to get the spinal cord injury. Our younger kids, 6 to 12, they are really keen with fitting in with their school peers, and they are still concrete thinkers. Adolescence is the tough year because throughout all stages, early, middle, and late, their self-concept, they have a concern with their changing body, they're concerned with attractiveness, their body image is key throughout all 3 of these stages of adolescence, and a spinal cord injury definitely changes your body image. Remember that kids under 13 still are concrete thinkers, and abstract thought doesn't start till about 14. And also our adolescents are wondering about what they're going to do next. So keeping that in mind with spinal cord injury and adolescence, we have to think about their privacy, you know, when we're examining them, security, coping, and socialization needs. We have to remember that that's all, their normal development is focused on body image, which is drastically changed. And some kids will regress. And when we think about longer term planning, a year out, sometimes we might consider a urostomy, an external way to self-cath, which is the old Mitrofanoff, which is the same thing through the belly button, and bladder augmentation for independence in bladder management. And we also have to wonder about fertility. And I put this picture up here to remind me that where I used to practice in Saudi Arabia, women where their main role was having children. And spinal cord injured girls and children were actually still valued because they could still be fertile. In men, that's a more complicated issue. So fertility is also something that parents and kids may not ask you, but is a concern in spinal cord injury. Next, we're going to move on to the medical management. And I like this little picture because it kind of summarizes everything. But I think for you guys and being practical, the top three things you might see on an inpatient ward would be the three things listed: neurogenic bowel and bladder, skin breakdown, and poikilothermia. And also key management is respiratory management, especially in our higher level spinal cord injury, and autonomic dysreflexia about T6. We're actually going to hit those two first and then come around. So respiratory issues in spinal cord injury. This is important because C4 is the highest level you can survive off a full-time vent. And that's in ideal circumstances, because you still have accessory muscles being innervated up to T12. You can see the intercostal accessories, C5 to T6, and the abdominal accessories, T6 to T12. So really, T12 and above still have some type of respiratory management. And this has implications for long-term planning. And we definitely want to minimize their mortality and PICU admissions. In spinal cord injury, it's important to recognize that respiratory issues are ventilatory. They are not oxygenation. Having nasal prong oxygen is not going to get adequate ventilation. And again, C4 and above always need a vent, and C5 and T6 with any challenge. So even if we are able to wean kids with C5 to T6 levels off the ventilator, they still need to have a backup ventilator when they go home. Otherwise, when flu season rolls around, they're going to have a pneumonia and require mechanical ventilation. And it's important to remember that in respiratory management, there are actually 3 steps in secretion, mobilization, and clearance. We always think of step 3, suction, but really it starts with mobilization. So mobilization, shake it up, whether by manual chest PT or a vest airway clearance system or by a special PICU bed. You got to shake it up. Step 2 is get it out, clearance. Okay, and that would be a cough assist device or insufflator, exsufflator if you don't have a strong enough cough. And again, all those kids above T12 are going to have issues with cough. And then finally, step 3 is suction. Okay, so remember, there's always 3 steps to respiratory cares in spinal cord injury, or actually in anything. Shake it up, get it out. Okay. The second problem is autonomic dysreflexia, and this happens in kids that are T6 and above. And basically what happens is there's a block here. So any stimulus comes up, and then it has a maximum sympathetic response with widespread vasoconstriction leading to hypertension, and it's blocked. The baroreceptors are trying to do something. They slow the heart rate down, but there's just no way that they can deal with this blocked sympathetic response. And what happens as a result is you get vasodilation above the level of injury and vasoconstriction below. So below the level of injury, they'll be cold with goose flesh, they'll be pale, and there's absolutely no sweating. And above the level of injury, you will see that they have flushed face and sweating, distended neck veins, a pounding headache, and they will have high blood pressures with a decreased heart rate. So what do we do about it? Well, we know that we have to identify the trigger, because that's truly what's causing it. There is some stimulus at T6 or below that is causing the autonomic dysreflexia, and identifying it is the first priority. Bladder distension, number one, and number 2, and number 3. And then unrecognized discomfort in the other things listed below, like restrictive clothing, my clothes too tight, or a sheet is folded and bothering me, or I have constipation or fecal impaction. There's something in the bed like a Foley clip that's pushing on my skin and I can't feel it, but it sets off a signal. Ingrown toenails, a skin pressure ulcer, burns, all these things can cause autonomic dysreflexia. So what do we do? Well, first we sit the patient up and elevate their head to 90 degrees and lower their legs. And then you start identifying and removing the cause of the stimulus. You take away anything that's loosened or any clothes that are tight. But again, number one is bladder, bladder, bladder. Check that Foley. Is the catheter blocked? Do they need to be internet in cath? Is there an overfilled collection bag? And then constipation. And then any of the other irritations listed below can cause it. Most kids have cessation of autonomic dysreflexia with recognition of the trigger and removing the cause. Very rarely do you have to go on to medical management, which is usually nitro-paste, because you can wipe it on and wipe it off because kids can quickly lower their blood pressures. Okay, but again, T6 and above, autonomic dysreflexia, less common in kids, but if it happens and you see these signs and symptoms, then sit them up, raise the head of the bed at 90 degrees, lower their legs, check their bladder, and find the cause. Okay. In our inpatient rehab unit that we're not allowed to open, we actually had all our nurses trained in neurogenic bowel and bladder, and we developed with the nurses an autonomic dysreflexia protocol. Okay, now we're going to move on to neurogenic bladder. And neurogenic bladder is a whole talk in itself, as is neurogenic bowel. But we're going to just summarize the key points here. There are two different micturition centers in the brain, and there's also another one in the spinal cord, S2 to S4. Also involved in this response are parasympathetics, POR, sympathetic store efferents, as well as somatic or muscle control and sensory afferents. And remember, there's all different types of bladder wall receptors, which are above the length of this talk. To summarize, there are two different types of neurogenic bladder, and you can see the normal bladder is here on the left, and then you have a hyperreflexive, tiny, tiny bladder. That's an upper motor neuron, failure to store, okay? And here is a lower motor neuron bladder, overstretched, tight bladder, tight internal urethral sphincter, cannot empty. So again, failure to store, upper motor neuron, tiny bladder, failure to empty, overstretched, tight bladder, lower motor neuron. Okay. And when we look at the causes of this, and this is just very brief, above the sacral micturition center, above S2 is upper motor neuron, failure to store, and we usually treat with a collection device or different medications like this. The lower motor neuron bladder is failure to empty, and this is very common in early spinal shock before any reflexes come back, or in cauda equina and cona medullaris lesions, or anywhere where there's complete destruction of the sacral micturition center or below. Okay, and again, this is the overstretched tight bladder, and this is where you need to do intermittent cath. Okay, so breaking it down into how to treat. Basically, in the PICU, it's going to be a Foley until spinal shock is over and the volumes are less than 2 liters per hour, and that should be 24 hours. And this is important because you're going to give a lot of fluids in the PICU setting, and if you try to intermittent cath and you're giving all these IV fluids, you're never ever going to be able to keep up. You're always going to be having too high volumes. So it's best to leave the Foley in until you have less than 2 liters in a 24-hour period. So if they come down to the floor and their volumes are less than that, then you might want to trial spontaneous voids and bladder scanning. So you take the Foley out and you start bladder scanning Q6. And then it will differentiate in between they're going to have spontaneous voids or they're not. Most kids don't have spontaneous voids. That means there's no reflex. This is a lower motor neuron bladder, and we have to worry about it getting overstretched. So we begin the intermittent cath protocol, Q4 to 6 hours. Most people start Q4. And then we bladder scan and cath if the volume is above 300 cc's or 300 milliliters or above the age expected capacity. It's important to make sure that the nurses are measuring and recording pre-cath and post-void residual volumes. In other words, Their bladder scanning Q6. They scan the first time. Oh my goodness, it's over 300. They cath. They write down how much came out with the cath. Then they scan again. That's called the post-void residual. And they check whether or not there's anything left in the bladder. Okay. And that's important because if you cath one time and you get less than 1/2 out, you're going to have to cath again. Okay. And that's what it means by if the post-void residual is greater than 1/2 of the age expected capacity, you have to do it again. And that's because we don't want this bladder to get overstretched, because it is a muscular bag. And if the muscles are overstretched, it's just going to become loose and then intermittent cath, and everything will not be as effective. So again, if no spontaneous voids, that's a lower motor neuron type bladder, and most of these kids are going to be intermittent cath Q4 to 6. So spontaneous voids, that's reflexive upper motor neuron bladders, and basically these are kids that you're already bladder scanning Q6, and if they're having some out and you catch them and you can do the post-void residual, the less than 1/2 you don't have to cath, but greater than you might want to. These are the kids that eventually will go on to have a collection device, and that's great if you're male, because there's all types of different collection devices for male, like a condom cath with a leg bag. But in females, it's much more difficult because we don't have great collection devices. Most of our kids tend to be lower motor neuron overstretched type bladders. Okay, so one question I get is, well, how big is the bladder in kids? In adults, it ranges from 300 to 600. Most of the time, think about small ladies are about 300 and huge men. So usually the cutoff is about 400. In our protocol for inpatient rehab, we decided to use 300 as the cutoff. There is the Kafer formula, which are mentioned here, and these are kids less than 2. It's 2 times the age in years plus 2 in ounces, and kids greater than 2, age in years divided by 2 plus 6. And again, to calculate ounces times 30 to get milliliters. So that's the Kafer formula, and it's because the bladder sizes don't go up. They actually have 2 different, it's not just a linear kind of growth. And if you do the Kafer formulas, you can see that at 18 months, that's about 150 mLs. 2 years, you're about at 210. 4 years, you're about 240. And 8 years, 300. So after 8 years, you might as well just use 300. Okay. All right. So that's all about neurogenic bladder. Neurogenic bowel, our goal is to get a predictable bowel movement. We want it to be the same time every day or every other day. And typically we try to train the bowel so that the child has a bowel movement at the same time, usually after the evening meal every single day. And why? And you can read the answers here. Bowel incontinence is not socially acceptable. It's hard to work or go back to school if you have incontinence and bowels, and it leads to a lot more image and mood issues, as well as complications with skin breakdown, pressure sores, infection, hemorrhoids, anal fissures, and not to mention untreated neurogenic bowel with constipation or even obstipation can cause autonomic dysreflexia in above T6. Okay. So again, sympathetic store, parasympathetics poor. There are actually 2 anal sphincters. Remember, the internal anal sphincter is involuntary smooth muscle from the parasympathetics, and the external anal sphincter is a voluntary skeletal muscle. Okay. There are 2 main reflexes involved in the bowel program, and this is an important reflex because it works in upper motor neuron and lower motor neuron nerves. And this is the natural tendency that we all have, that after you eat a meal or have a hot beverage, 20 to 30 minutes later, you naturally want to have a stool. So it's important to plan a bowel program around this gastrocolic reflex. The retrocolic reflex is the second one, and unfortunately, it only works in upper motor neuron lesions. And this is, you have increased motility after stimulation of the rectum or anal canal through digital stim or a suppository. Okay, so to summarize the neurogenic bowel with upper motor neuron, lower motor neuron. Again, you can see T12 is the dividing line, and you have a reflexive bowel, T12 and above. So both reflexes will work, the gastrocolic and the reflex defecation with digital stim, but below T12, only the gastrocolic reflex will work. Okay. I'm sure a lot of you have questions about bowel medications, or this is something that you're often asked to do when you're on the ward. And the bowel medications and spinal cord, they help, but they don't substitute for proper hydration, diet, timing, positioning, and dig stim. Stool softeners. If you need to add water to the stools, so you need to make it slippery, then Colace is usually the one that you need. Too hard, add Colace. If it's not coming down the colon, or you need to have a promotility agent, then Senna is typically prescribed, and think that this needs to be prescribed 8 hours ahead of time, because that's how long it takes to work to have a bowel movement. So if you want to have a planned bowel movement after dinner, then you want to take your Senna in the morning. If you need to even have more irritant or osmotic laxatives, then Miralax can be used, or Dulcolax, but not lactulose. And if dig stim is not enough, you might want to add Enemies or a Magic Bullet or Biscotal suppository. Finally, if you don't have a bowel movement greater than 4 days, now you need to worry about completely emptying the bowels with either a Viscerin enema or milk and molasses. And milk and molasses is the most effective bowel disimpaction enema, in my opinion, and it's in fact what we usually use on the inpatient rehab ward, especially when kids get really impacted. Also, if you're wondering whether or not you need to do an enema, you can always get a KUB and check to see the stool burden and if there's any obstipation, which is a partial kind of blockage. If there's obstipation, you definitely need to get an enema done. Okay, and again, we also developed an algorithm for neurogenic bowel as well as bladder. This is the bowel one for the inpatient rehab unit. Okay, the other two main medical problems in spinal cord injury that you may encounter on the ward is one, skin ulceration, because remember, this is insensate skin. You have to check areas that are shown in the little picture here. Also, the occiput is a big one, a lot of alopecia. We don't want it to break down. So there's already a Q2 turning protocol on the wards, and there's also specialty mattresses. And these are things that will carry over into the outpatient setting as well. Temperature dysregulation. It's called poikilothermia. Poikilo is snake-like. So in other words, kids with spinal cord injuries take on the temperature of the environment, just like reptiles and snakes. If the environment is too hot and they've got a lot of blankets on, they're going to have an increase in temperature. If it's too cold, they're going to also have a lower temperature. So this usually happens greater than T6, just like autonomic dysreflexia, and it's because of the loss of central control of the sympathetics. So again, poikilothermia, #1 cause of a increased temperature without actually having a temperature. So when you get that phone call, have the nurses take off all the blankets and recheck the temperature before you act on it in spinal cord injury. Again, DVT, we mentioned briefly before, it's much more when kids start to look more like adults. So post-pubertal, very few in kids, but if you're going to have to treat, mechanical compression stockings are fine in all ages. If you're going to have to treat with low molecular weight heparin in complete spinal cord injury, the proper duration is 12 weeks. Pain in spinal cord injury can be different things. So dysesthesia, like annoying kind of sensations, versus painful neuropathic pain. That's important to differentiate. If it's just annoying, I don't recommend treating with neuropathic pain medications. Only when it's painful would I treat. Spasms, which also can refer to spasticity, initially they can be just annoying, but when they become painful or when they start having spasms and spasticity with leg jumping to the point where it interferes with transfers, then we start treating it. We use narcotics sparingly, just as in other pediatric cases. So some of the early challenges moving from the wards to the inpatient rehab unit we discussed already. Autonomic dysreflex above T6, watching that how many blankets are on, whether it's an actual temperature versus poikilothermia, plasticity, which is how kids with spinal cord injury start out, and then the tone and spasticity come in later, and we want to prevent the complications as listed below. One of the main things that we see more when we start mobilizing them in inpatient rehabilitation is postural hypotension. So when kids with spinal cord injury start being moved from supine and elevating the head of the bed, they can actually have lower blood pressures, and we have to gradually elevate the head of the bed. And then in the rehab unit, we use this stander, and it actually starts totally horizontal, and then it elevates gradually as they can tolerate. Because of this reason, we also have built a specialized long shower in the inpatient rehab ward so that kids can take a shower lying down without having postural hypotension. In our acute rehab goals, our independence and mobility transfers and EDLs is listed, and there are different functions at different spinal levels. And I'm just going to summarize these levels with the next slide because this is a whole lecture in itself as well. But the key levels for independence in ADLs and manual wheelchair propulsion is C8 to T1, okay? And will I walk? Very common question after spinal cord injury. So remember, T12 and higher, you have trouble with trunk support. L1, if you're a little kid, you might have this reciprocating gait orthosis for exercise, but you're going to use a wheelchair for long distances. L2 to L3, again, you're going to use the wheelchair mainly. This is not a functional way to ambulate. And really, you need good quads to functionally ambulate. And so that level L4 is when most people can become community ambulators. Okay. L5, S1, you'll need AFOs, remember ankle foot orthosis. And then some people with these levels just might need shoe inserts only. So again, L4 is the level when the quads are now innervated and you can functionally ambulate. And C8 to T1 is when you can start doing things because you have good enough hand function to do some ADLs or transfer. And again, this little cartoon reminds me to let you know that many people with spinal cord injuries prefer a wheelchair because this is very inefficient and this is much more efficient. Okay. So what do we do for the people that don't have enough innervation? Well, we have this piece of equipment, yes, also on the 5th floor, and this is an arm and leg ergonomer. So this young lady can't move her arms or her hands independently, but with functional electrical stim, we can stimulate and actually move her leg or her arm for her while she's playing a game to get increased tone in the muscle itself. A good, like good tone, not like bad tone spasticity. And if she should have more recovery, we can turn the resistance to a level that she can independently do with recovery as she gets stronger. This is our Excite, and this one does the same thing for the arms, but with a program sequence of stimulation. This helps him extend his arm out, grab, and then bring to mouth. And for our kids that only need peripheral stimulation, the walk aid might help function in just a foot drop alone. So functional electrical stim is something that is beneficial for exercise, toning muscles, and recovery in spinal cord injury. Okay. Well, our kids are different from adults because we also have to worry about the effects of growth. And spasticity increases as time goes by, and we need to continue to do passive range of motion and position kids properly in splints and braces to avoid contracture. Just like in cerebral palsy, if you cannot hold your trunk up independently, in spinal cord injury, gravity will take over and you will eventually get neuromuscular scoliosis. And so we need ortho follow and surgical management for neuromuscular scoliosis. And finally, you can also have hip subluxation. Other complications are pathological fractures secondary to osteoporosis. And we want to combat this with weight bearing, whether in a stander or other type of weight bearing apparatus, calcium, vitamin D, and sunshine. We also want to screen for vitamin D levels as well. Spasticity we talked about, which can lead to contracture. And then the last thing I really want to point out is syringomyelia. And this is important because this is a little syrinx. You can see the cyst in the spinal cord. And that can cause new changes. So kids that had good arm function, but now have a change, especially on one side, that needs further investigation to rule out syringomyelia. So any change in function, any change in neuroexam, think, could this be syringomyelia? And it needs imaging and neurosurgical consultation. Again, syringomyelia, change in neuro, change in function. Okay, less common complications, heterotopic ossification, bone where it doesn't belong. The treatment is range of motion. NSAIDs, we don't do Dindranil because it can cause early closure of the growth plates. And you do only surgery in HO if it's very, very painful and it's greater than a year out, because otherwise the HO is not mature and can come back. Sorry. And in teens with tetraplegia, usually 2 to 3 months out, sometimes it can be earlier or later, they have nausea, anorexia, lack of energy, polyuria, and polydipsia. Think of immobilization, hypercalcemia caused by increased in osteoclastic bone reabsorption, and they need to be hydrated with Lasix and calcitonin. Okay, so what about recovery? Okay, so really we're only at the compensation level because neuroplasticity, and there's not really repair. There's a lot of mouse experiments going on, but nothing that kind of has been shown to be effective in humans yet. So really we're doing compensation. And I tell families that most of the recovery occurs in the first 6 or 9 to 12 months. Okay, that's when we see the biggest changes. Kids have a little bit better recovery in some studies than adults. But again, if the poor prognosis are high energy mechanisms, a distracting injury, or a complete injury. Okay. So if you have a complete injury, remember Asia A, there's nothing getting down through that spinal cord. There is no sacral sparing. You only have the potential for regaining 1 to 2 levels below the level of injury. So not very good recovery. If you're incomplete, Asia B and E, you have a little bit more potential, especially if you have anti-gravity strengthened muscles. So here by Asia level, and we didn't go over these before, but I can explain them pretty simply. A is complete spinal cord injury. No case of a functional improvement. Asia B, that's sacral sparing. Maybe 1/3 will have a functional improvement. Asia C, and this is less than 50% of the muscles have anti-gravity strength below the level of injury. 3/4 can have functional improvement. And then Asia D, almost all of them improved, and that's because they have greater than 50% muscles below the level of injury, greater than 3 out of 5. So these are anti-gravity strength. This is the number of muscles below the level of injury. So you can see as you have more muscle movement, especially 3 to 5, you have a better prognosis. Unfortunately, remember, pediatric, cervical, and a lot of cervical complete. Okay, so outcomes, you can have increased musculoskeletal problems with aging because you have the spinal cord injury for longer. These are mentioned here. And again, scoliosis and hip subluxation. Okay. Finally, several studies show that children with spinal cord injury actually do well in school with above average participation and performance compared to peers. 91% graduate high school and 84% are college bound. And 71% of the kids with spinal cord injuries that are college graduates are in the workforce compared with the general population rate of unemployment of 40%. So kids with spinal cord injury do better in school, they go on to college, and they go on and get employed more than the general population. They also report higher quality of life than adult injured. Okay, so can we do anything to prevent spinal cord injury in peds? well, we could prevent motor vehicle accidents if we can keep kids out of the front seat and appropriately use child car seats. And you can see the decrease in injury and death, and keeping children from falling out of windows, safe sports, and can we reduce gang violence or gunshot wounds in our communities? Okay. All right. So this is where please take your things off mute. And we have 5 questions and then a summary. So question 1, a 3-year-old status post to Asia A C2 spinal cord injury from a motor vehicle accident has a temperature of 100.4. What should you do first?
You could obviously assess the patient and see if he's in any discomfort, but first consider either cathing or trying to see if we can remove some urine out of his bladder.
Okay, that is a perfect answer for autonomic dysreflexia. Any guesses for poikilothermia?
Uncover the patient first.
Exactly. So this is an example of poikilothermia, and make sure they're not bundled and recheck the temp without blankets. Okay. And you will get a lot of calls on this. And the last thing you want to do is all this blood work if it's unnecessary. Okay. So question 2, this same patient just came down out of the PICU with a Foley. The Foley output is less than 2 liters per day. Nursing wants to know the next steps for bladder care and wants to know if you want to remove the Foley to avoid a UTI. What do you recommend? Anybody going to remove the Foley?
I would bladder scan them first, and then see if they can remove the Foley.
Okay, so yes, you could actually remove the Foley, and you can do the bladder scan just as you said. And I would start with Q6, and then I reminded you of the bladder capacity there. And if they don't have any spontaneous void and their bladder capacity is greater than 210, then you would cath them, and then you would scan again, check the post-void residual, and cath again if it was greater than 1/2 the expected volume. So the short answer is yes, remove the Foley and trial spontaneous voids with a bladder scan Q6. And then the second half of the order would be cath if volume greater than 210 or post-void residual greater than 100. Okay, and most likely these kids are going to not be able to spontaneously void, and then they can begin the intermittent cath protocol. Most people start with Q4, and then you put your volumes and your post-void residual volumes. And the most important thing is, and in case I didn't say it before, if the nurses don't record these volumes, they don't help you. And that's hard because it's not fun or easy to chart in Cerner, but you want them to record the bladder capacity before the cath and then the post-void residual, along with strict I's and O's. Okay, so the short answer is here, yes, remove the Foley and trial spontaneous voids and bladder scan Q6. Okay, what are the 3 steps in secretion management?
I know the first 2, it was mobilization and then clearance, but I can't remember the third one.
Okay. And I heard the first step, I believe. This is the easy way to think about it. Shake it up, mobilize it with a vest or manual, get it up with a cough assist if they don't have a good cough, and then finally suction, get it out. So shake it up, and get it out. Okay, question 4. What is the highest level one can possibly survive off a vent? And at what level are all accessory respiratory muscles innervated? Any takers? Okay, I'm going to help answer it. So C4 is the highest level in the ideal circumstances. And remember, below T12, you still need help with something. And you need vent with challenges C5 to T6. Last question. The parents of your 3-year-old with ASIA A C2 spinal cord injury want to know the following. 1, will my child walk? And 2, will they need the vent when they go home? Any takers?
So with a C2, they will likely not walk. And then they will probably also need a vent going home.
Exactly. Okay. So they know because they're a complete injury. They're at best, they're going to have only 1 level, maybe 2 levels below the injury. So C3, maybe C4 if they're lucky. And they need to be at least L4 for a community ambulator. Will they need a vent? Yes. And again, C4 is the highest level and they'll still need it for the flu season. Okay. So here is the summary. Spinal cord injury, very high incidence of peds spinal cord injury compared to nationwide and internationally. More cervical injuries in peds than adults, less DVTs unless they're adult size. Watch the respiratory needs, especially in higher level. Ventilation is the issue, not oxygenation. C4, the highest level off the vent. And T12 and above, watch flu season. Autonomic dysreflexia, T6 and above. And the person that answered what to do with AD was exactly right on. Sit them up, elevate the head of the bed, put their legs down and identify the cause. And usually neurogenic bladder is the first. Remember that call about temperature and spinal cord injury. Make sure they don't have lots of blankets on, read poikilothermia. Syringomyelia, any new neurodeficit. And I put the key levels down here again, and then preventing with proper car seat and seatbelt use. Education is important. Any questions for me? Any questions? Okay, if not, then thank you very much for joining, and I appreciate your attention, and I hope you have a great Monday, first one back.
Thank you.
You're
Thank you,
welcome.
Dr. Wunderlich.
You're welcome.